Thank you very much, Northern Ophthalmological Society, for giving me this opportunity. Dr. B.S. Bohra, Dr. Sajad, Dr. Rajan Gupta, and Dr. Sudhir. They are our chairman and representative, and Dr. Satanshu Mathur. Uh, I will be speaking on phacoemulsification in DME. DME means diabetic macular edema with Ozurdex implant. Cataract surgery may cause progression of diabetic retinopathy and worsening of the DME. Steroid and anti-VEGF agent have been tried and has been adjunct to overcome this progression. And goal of the cataract surgery is to achieve in the back placement of IOL, avoid vitreous loss, and have clear cornea and good visual outcome. But what happened in these DME patient is that there may be worsening of the macular leakage. There may be poor visual outcome despite you do excellent cataract surgery, and ultimately dissatisfaction of the patient. This is one of the slides showing after cataract surgery and PC rent, there is increase in the, there is a vitreous hemorrhage and NVD and increase worsening of the diabetic retinopathy. This is our study in 2013 where Ozurdex implant were injected, and this was published in ophthalmology. That point of time, FDA approved Ozurdex. So this is one video. Combined phacoemulsification and Ozurdex implantation. 55-year-old female with history of NPDR with CSME. This is a nuclear cataract. You can see the fundus. This is before surgery. You see the cystoid macular edema. And then we did phacoemulsification. There are several studies which we have published from PGI, which shows a better outcome after injection of Ozurdex implant. We can, usually I inject it before starting phacoemulsification because pressure of the globe is better. It is injected at about 3.5 millimeter from the limbus. After injection, this continuous curvilinear capsulorhexis, hydrodissection, and then stop and chop technique was used for removal of the cataract. Emulsification become easier in these. This is not a very hard cataract. This is grade 2 to 3. And then removal of the cortex from the capsular bag. And implantation of IOL into capsular bag. You can see Ozurdex implant moving. The use of intravitreal injection of DEX implant along with phacoemulsification is safe and facilitate reduction in the macular edema. And you see this one case where Ozurdex is injected in a patient with diabetic retinopathy and IOL implantation. There is improvement in the visual acuity and resolution of diabetic macular edema, as you can see in the slide. Ozurdex Dex implant was administered per-operatively at the beginning of the surgery. Dex implant was administered via pars plana directly into vitreous cavity at the end of surgery. Usually I inject it before surgery. There are some group of people, they inject, or even sometime our retinal surgeon, they advise to inject it about a week or 2 weeks before surgery. So all the three modalities are viable. In conclusion, always inform the patient of likely possibility of decrease in the visual acuity after cataract surgery in DME or moderate to severe NPDR changes pre-operatively. Evidence-based data and real-world experience favors use of DEX implant, that is the Ozurdex, before or simultaneously with cataract surgery for DME because of better control of post-operative inflammation and 3-month efficacy. Treatment of DME before with anti-VEGF, triamcinolone or laser may be considered second line of therapy. Take-home message is cataract surgery is not an emergency. Maintain strict diabetic control before cataract surgery. Pre-operative retinal involvement with macular edema may be treated with anti-VEGF or steroid implant. Intraoperative anti-VEGF or sustained release steroid implant have become the standard of care. Meticulous cataract surgery must be done by an experienced surgeon. Planned postoperative care in collaboration with retina specialist. Avoid worsening of diabetic retinopathy status. Thank you very much.
Very nice presentation, sir. Yes, I would like to just ask why did you put, sir, multi-piece IOL?
Oh,
3-piece, I mean.
Studies, this is one case, but there is ultimately when it is a square edge IOL, I have at least 10 to 12 studies, and literature also shows square edge IOL, whether it is a single piece or 3-piece, make no rate of the PCO difference, no difference in the PCO rate. We use most often single piece IOL, but it does not matter whether in this case or in other cases, if 3-piece IOL is used, which is a square edge. So no difference in the PCO.
Sir, a very excellent presentation. I would like to say, sir, do you use DEX implant in all diabetic macular edema cases during cataract surgery?
Usually what we do, we take opinion of our retinal surgeon. Many a time they say that it is better that you use it a week or 2 weeks earlier, because by the time we do cataract surgery, macular edema may come down. But many of the time seeing the, if there is no swelling or there is a mild swelling, they may say that okay, do in one sitting. So we have to see so many factors. That is the opinion of our retinal surgeon. So both are, otherwise, as studies have shown that both are equally effective, because once Ozurdex is implanted, its efficacy is for close to 3 months or so.
Agreed, sir, but I think ultimately it is the diabetic control which is very important.
No, that is,
and most of these patients require multiple injection. Even if we give Ozurdex, that doesn't mean that is the end of the story.
No, you are right.
So multiple injections and maybe one Ozurdex will not work. Only in certain circumstances, as lightly mentioned by you, you have a diabetic patient, you have a macular edema, and there is not much of the diffuse leakage. There that might work. Ultimately, you need repeated injection and a strict diabetic control.
I agree, because one is control of diabetes. That is the most important. That is number one. Second thing is, usually they will need multiple injection.
Sir, what about steroid responder for the IUP rise after?
I think we have carried out study which is published in Indian Journal of Ophthalmology, one in published in Ophthalmology 2013, and in Indian Journal of Ophthalmology about 2-3 years back. So that both have shown that there were no, because this is 700 microgram. It does not produce glaucoma.
I think it is one of the safest
Yeah,
drug,
safest
as
one.
sir has mentioned. So you can use these drugs. If it is required, you can use Ozurdex even in steroid responder, because the rise of IOP is not that dramatic in cases of Ozurdex as compared to the other drugs. But you should avoid as far as possible. If you, yeah, you go and you just eat it up. But in very rare circumstances you require those.
Yeah.
So it is a safe, very safe drug, and very effective drug, I would say.
Yeah, surely. Thank you so much. Thank you so much.